Hi everyone, my name is Katie Kuntz and I'm here to present my proposal in poster form. Before I get started, I'm sorry you're out of boxes. This is my third time trying to film this without you falling, so. Anyways, you do have a handout next to the URL in the comments, so basically that's going to be all of this word for word. So you got your abstract, introduction, all my steps of my proposed study. And then I've got these graphs so you can look at those close up. And lastly, my expected results, my conclusion. What I'm going to be talking about today is coagulation. I don't know how many of you maybe work in coagulation. I know some of you it might not be, the most interesting topic in the world, but topics like this is very important because it does impact, patient care, which is, as a laboratorian, is, the most important part. So my topic is the effects of edoxaban on coagulation assays to suggest unreliable testing methods. Let me go ahead and start with my abstract. Abstract over here. So, if you don't know, edoxaban is a direct oral anticoagulant. So basically, it's what a lot of you would call a blood thinner. It's going to stop that clot, at the source. And so, as you would think, a doctor is probably going to order your PT and your PTT to anyone who has, different clotting abilities. But, I'm here to propose that these, the PT and the PTT is not going to be an accurate depiction of edoxaban concentrations in the bloodstream. And I thought of this because there are other more common direct oral anticoagulants that people take, apixaban and rivaroxaban. For example, I hope I said that right. I think so, yeah. They work kind of similarly to edoxaban. And, there are a few articles online about how, their different reagents especially are causing a variation in results that could actually impact patient care. The most important reason a doctor could need a PT, PTT, as far as edoxaban goes, is there patient overdose? Does the patient need invasive surgery? Because if so, you don't want them to bleed out because they've been taking a blood thinner. So that's why I think this is important, and I'll go ahead and tell you my hypothesis. It's that different reagents and tests show variability that can be of clinical significance. My expected results are that PT and PTT will be prolonged in a non-linear fashion relative to edoxaban concentrations. Let me scroll down. Oh, okay. I did put this in your handout. It's the intrinsic-extrinsic pathway, and I'll touch on that in 2 seconds. So, what is clotting, right? I'm sure most of you know this. I'll go ahead and, explain in basic terms. Clotting is a mechanism that our blood uses to prevent us from bleeding. If we got a cut, we would want a clot to form, right? So the clotting cascade is our body's rapid response to our injured vessels, which would be this graph. So you can look at yours there. You've got your two pathways, your intrinsic, your extrinsic, and then they meet at the bottom for factor X, which is actually common in both. The reason we're talking about that is because, like I said earlier, edoxaban is a factor X inhibitor. That's how this drug prevents clotting. So routine coagulation testing is useful in many patients to, detect the ability to clot, but for those taking medications, I'm proposing that routine testing isn't reliable. I did write that edoxaban is the least studied. I really couldn't find anything studied on edoxaban as far as coagulation testing goes, which is kind of crazy because clotting and coagulation go hand in hand. let me go over the purpose of the studies determined if patients can be reliably evaluated using routine coagulations like PT and PTT. Because it is valuable to have these results for patients going under emergency or invasive surgery. Yes, anti-XA assay is going to be my suggested test, and the reason I chose that is because it's quantitative. You know how much is in the bloodstream. You're not going by seconds of a PTT test, right? Let me go through the methods and results, which is basically the steps of the study. I purposely made it extremely simple because we don't want to, we don't need to complicate this. All we need is 20 healthy patients. Find sample size of 20 healthy patients, preferably 10 male, 10 female if you can, just for, Okay, then we're going to get a phlebotomist to draw 2 of our blue top 2.7 milliliter sodium citrate tubes. And I actually wanted you to see this right here. So first things first, we're going to take the samples, spin them in the centrifuge so we can get the plasma. Plasma has fibrinogen, which is why it is used in coagulation tests. And then we're going to take it to the lab and put it in one of these aliquots. We should be able to get 9 aliquots out of this plasma because it really doesn't take very much plasma at all to run a PT or PTT or anti-XA assay. Next, we're going to put it in the freezer, and it can be stable at negative 70 degrees, 75. And then we're going to run it on 3 different coagulation assays, or coagulation analyzers, for this one, different reagents and different analyzers. Specifically, we want to do Innovin because it's shown unreliable testing with other DOACs, so just short for direct oral anticoagulants, Trenaclot, and neoplastin for PT. Next we're going to use, so the way we're going to manually add it, we're not just going to crush the drug up and put it in the sample, right? So we're going to actually dissolve an edoxaban salt into a dimethyl sulfoxide solution and then measure that in nanograms and put it into each aliquot, and that will be predetermined. So basically, most patients will get at their trough concentration, which is, right before their next dose, how much is in their bloodstream, about 50 nanograms a milliliter. And the most, right after they take it, it can be between 100 and 275. So we're going to focus mainly on that, but we will go up because as concentrations go up, I think it's actually going to get even more and more variable as to your results. And that's actually pretty important if you're suspecting, maybe your patient took too many. So we're going to actually add concentrations from 0 to 1,000. So 25, 50, 75, 100, 150, 250, 300, and then 400, 500, 700, 800, 1,000. So the question, what's the big question to ask as far as this goes? Does edoxaban concentration increase as PT and PT increases? I'm sure most of you know PT and PTT are in seconds. So let's say a patient took 100 nanograms a milliliter. What is their PT going to be with Innovin? What's it going to be with neoplastin? And if, let's say, with Innovin, their PT is 25 seconds, but with neoplastin it's 45. There's a variability there that, you know, I'm not very fond of. I don't think it's very accurate. You know, you don't, 25 and 45 is pretty different when it comes to a PET. One is a lot higher than the other. Next, we're gonna add our points into a statistical software so we can look at it. There's gonna be two different ways we're gonna look at these. For the PT and PTT analysis, we're gonna be looking at a mean of standard deviation. It's different than a standard deviation. It's not gonna be a bell curve. And for the anti-XA assay, which is what, you know, I'm proposing is going to be the most accurate, at least up to 500 nanograms a milliliter. We're actually going to use the coefficient determination for that, which is going to be your second graph right here. So the higher your R2 value is, the more accurate. So the R2, the example that I did put in the handout, it's pretty close to 1. It's not perfect, but we're gonna want something similar to that because you can tell that it is a straight line in a way. So really, why is this so significant, right? You know, doctors need to understand how to interpret these common assays. I am looking at your handout, make sure I'm following along. Okay, so what the main point is we really want to prevent patient bleeding events. Previous studies assessed on rivaroxaban, a common anticoagulant with different reagents, discovered a high degree of variability. So the significance is that patients could be at risk as specific doses, you know, might be given based on, you know, your lab results are long. You know, I'm saying don't do that. If you're going to base on anything, base it on the anti-XA assay, because that seems to be a much more reliable method. So, expected results, it's going to be similar to other factor XA inhibitors that have had studies done on them. PT and PTT will be elevated as concentrations go up, but it's not going to be perfectly linear. You know, I'm saying PT and PTT should only be used to screen, not to suggest how much edoxaban is in the bloodstream. And likewise, you know, normal PT and PTT shouldn't suggest that there's no edoxaban in the bloodstream at all. And, you know, this can open the floor to doctors and scientists alike. Okay, you know, if we can't use PT and PTT and just anti-XA assay, maybe we can, you know, discover more reliable methods of detecting these, you know, therapeutic ranges and what's best for the patient. So I'm hoping that the R2 values for the anti-XA assay will be greater than 9.9, except for after about 500 nanograms a milliliter. There's a little bit of variability, but it's still going to be pretty linear. And I think that PTT will go up, you know, if you have a really high amount, but it's not going to be linear. I think especially Innovin is going to show a lot more variability in its results comparatively to neoplastin. I think that's it. So thank you very much for listening to me. If you have any questions, comment it. And then, of course, lastly, hopefully an article in a research journal someday.